Hi, I'm Ryan Clouser, one of the ICU doctors in the NICU, and they asked me to come here and speak to you today about our new sedation protocol, which maybe some of you have been seeing used. And also we're going to talk about delirium assessment and how we need to be evaluating patients for ICU delirium and how important that is on affecting our patients' outcomes and their duration of stay in the ICU and long-term complications. So it's going to be pretty quick. We can all answer questions at the end. But I just basically took a couple slides to just kind of review our new sedation protocol. And the goal of this whole project was to obviously optimize treatment of pain, which I think in both ICUs everyone's always done a really good job of making sure that pain's well treated, no matter what the cause. And then once pain's well controlled, then start treating with sedation and then evaluating for agitation and delirium and using different agents for those situations. And overall, our goal is to get patients off the vents faster so they can leave the ICU, because we all know how full ICUs are and how few beds we have, and there are always people waiting to come in. So we need to keep people moving, and if we can be careful about how we're sedating people and treating delirium, we can hopefully decrease their days on the ventilator and get them through faster. The new protocol really is going to try and incorporate a delirium assessment method, which maybe you already saw earlier. You have a sheet with the CAM ICU screen on it. And this is really just catching up with how modern ICUs provide sedation and analgesia. We're beyond the days of Ativan drips and morphine drips. We have better options. We should use them because there's a lot of evidence to support staying away from benzos and heavy sedation for long periods of time. Okay. So for analgesia, our new protocol, obviously you're going to be assessing pain and always treating pain first before you give any other agent, either in a bolus or continuous infusion. The new protocol, just kind of like similar to now, has scheduled and PRN dosing as part of it. There are not going to be any more ranges for your pain medications, so you're going to get a dose and you're going to have to change it. It's not going to be ranged, so that's a little different. As far as PRN dosing, for examples, for morphine, 2 to 4 milligrams would be okay, and fentanyl 50 to 100 every 30 minutes. The key is really the time frame. We're going to be a lot more aggressive. It's not going to be Q1 or 2 hours. It's going to be every 30 minutes now, so that we're really on top of it. For infusions, everything's always going to start with a loading dose or a bolus dose, and then with the goal of rebolusing with 50% of the continuous infusion every 30 minutes until we get to a good place where the pain's well controlled. I just put some examples of different agents on here. I think the most common we use here is our patients usually aren't typically necessarily what we would call stable. Well, it's all relative. We typically generally probably use fentanyl more than anything, right? Both ICUs. So we're still going to do bolus doses and then start an infusion, probably around 50 mics per hour for a starting dose, and go up from there. For sedation, this is a new thing now. All sedation orders are going to have to be associated with the target RAS. So that's the Richmond Agitation and Sedation Scale, which you probably all know very well, right? So we're also going to be asked to document and assess the RAS every 4 hours and as needed. And then this is probably something that doesn't happen as often, is really going to try and have you all notify the intern or resident if we're not achieving our goals. We have to reassess and try something new. So if the RAS is off by 1 in either direction, we need to either decrease the sedation or increase it to get to our goal. So unless contraindicated, all the sedation orders should have a daily awakening assessment linked to a spontaneous breathing trial. This is well validated that daily awakenings, and there's actually data now that suggests using no sedation in ICU patients, because they get off the ventilator faster, they have less time on the vent, less days of delirium. So they all must contraindicate. So contraindications, if you don't remember, are hemodynamic instability, high vent settings, high FiO2, high PEEP, maybe arrhythmias or some kind of horrible airway compromised situation where we don't want to lose our endotracheal tube. And I already wrote that down, see? So neuromuscular blockers would be another reason to not do awakening trial. Drug-induced comas for status epilepticus, which the SICU nurses made. Well, you probably see it because we have patients in there all the time now. Get ready. Alcohol withdrawal, traumatic brain injuries, or open abdomens may be contraindications to awakening. So here's the Richmond Agitation Sedation Scale. For the most part, our goal is always going to be 0 to -1. So we're going to want patients a little drowsy but easily awakening, able to follow commands. We don't want them at the comatose heavy sedation level. We also don't want them in the hyperactive delirium agitation side of the scale. So really shooting for 0 to -1. Maybe a sicker patient, you want to go a little heavier. But we want to keep it as light as possible, still keeping the patient comfortable. So this is another kind of change. Well, you're probably already doing this, but it's more formal now in our new protocol. We're trying to get away from continuous infusions of sedation agents unless the patient's mechanically ventilated, obviously, although dexmedetomidine is a drip that we can use with a non-intubated patient. There's no suppression of the respiratory drive, so that would be a potential continuous agent you could use in a non-intubated patient in ICU, and that would be probably the only one that would be safe. But we're always going to try and start off with intermittent dosing of sedation because our goal here is to give the least amount as needed. Because I think we've all seen a situation where you start a patient on a midazolam drip and 24 hours later they're on 10 milligrams an hour. 2 days after that, the drip's been off and they're still not waking up. We want to get away from those situations. Well known that does not do your patient any favors to keep them snowed, laying in bed for days and days without waking. So our choices of sedation, and anyone that's on a neuromuscular blocker has to be on some scheduled sedation. That makes sense. We're not trying to torture anybody. Anyone who's hemodynamically stable, we're usually going to try and go with propofol first. Propofol has kind of the best pharmacokinetics for us, fast on, fast off, very short acting, versus using intermittent or continuous dosing of benzos. So really, the other thing we're doing is trying to eliminate continuous benzo infusions. There are a couple points where that may be indicated, but basically this is a copy of what the new algorithm looks like for the residents that are going to be putting in these orders most of the time. Obviously we're assessing pain. If there's pain, we're going to treat the pain. If they're not at their goal RAS and not a candidate for sedation interruption because maybe they're unstable, we're going to start off with PRN Ativan or a propofol drip if hemodynamically stable. If they are a candidate for daily sedation interruption, we're going to try and institute the CAM ICU every shift. So, and this isn't just for nurses to do, the residents should be learning how to do this as well. So we'd like to have this incorporated into your RAS assessment to have an idea if the patient screens for delirium, then we should be looking for reasons why they're delirious, or if there's any medications we need to change, or any other medical problems we need to address. And if we see positive screens for delirium, then we're going to start some kind of treatment, whether it's an atypical antipsychotic or Haldol. We're going to really try and do that. We want to get away from treating agitated patients with more benzos, which is typically what happens. And everyone's guilty of that. That's not what the patient needs. When they're delirious and agitated, they don't need more benzos. They need some kind of antipsychotic drug. If they're hemodynamically stable, then we're going to go down to propofol for first line. Second line choice may be dexmedetomidine. If someone's really requiring a lot of sedation and PRNs are not working in a hemodynamically unstable patient, then and only then, with attending approval, will we move towards probably a midazolam drip. Okay. So that may not be much different than what you're doing in your normal life, but we've kind of made it a little more formalized. Okay. This is just a fancy picture I found looking at the ABCDs of critical care. So really the focus should be on keeping patients awake, doing spontaneous breathing trials, getting them early aggressive mobilization, screening for delirium and treating it, all in the hopes of getting them out of the ICU quicker. And that's really all I have to say about that. 1 second. So lastly, what I'd like to do is show you some stuff about delirium, because, I don't know, is anyone here a delirium expert? You kind of know it when you see it though, maybe? So, these slides are from Vanderbilt. This Dr. Wes Ely is kind of the world expert on ICU delirium and all the bad side effects that come along with it. There's a ton of research in this field. And in the past 5 to 10 years, it's really become an important part of what we do, and I think we're just trying to instill the importance of this onto the ICUs and change the culture a little bit so that we have better patient outcomes. And these slides are free. They're all available on ICUdelirium.org, which is a really good website that you might want to look at if you're bored or have nothing else to do, because it really gives you a lot of good information, and it also has good examples of all the stuff about CAM ICUs on there, all the data backing it up, all the papers they've published, which is a lot. It shows you examples of how, maybe you've already seen this video, of how to do a CAM ICU bedside. Because reading the paper might be a little confusing, but once you see it done, it's actually not too hard and shouldn't take a lot of time. But basically, I just want to show you some of the background about how big a deal delirium is, how common it is, some of the horrible outcomes that occur when patients get delirium in ICU, how we're going to monitor for it, how we're going to manage it, and how we're going to help change our culture here. So here's some background slides. It's very prevalent. Patients who are intubated, there's up to 80% chance of getting delirium in ICU, and it's pretty well correlated with their severity of illness. The sicker they are, the more likely they are to get delirium. So your patient who's on 2 pressors and multi-organ failure and CRRT and ventilator, they have a pretty strong chance of getting delirious at some point during their ICU stay. They estimate 40,000 patients get delirious in ICUs every day. Up to 10% are still delirious and having trouble when they leave the ICU. Another thing you need to remember, and there's more slides on this, some of these are a little redundant, but the age of our patients is also very well correlated with their chances of getting delirious, and it's almost completely related to their age. So if they're 75 years old, there's a 75% chance they'll get delirious. If they're 88 years old, 88% chance roughly. It's very highly associated. So it's very common. The good thing is most patients that get delirious, even if we do nothing, delirium typically resolves by day 3 or 4 in up to 80% of patients, if at least we recognize it and start minimizing the risk factors for delirium. And I think the other thing I want to drive home is that delirium is not always the patient who's trying to jump out of bed with Hulk strength, pulling at their ET tube. Delirium really is sometimes not so obvious. And actually there are a couple different types of delirium. We think of the agitated type, we call that hyperactive delirium. That's actually the least common type of delirium. It's just the kind we think of because it's obvious, a little more obvious. But there's actually a hypoactive subtype, which is about 1/3 of patients, which are the patients who are eyes open, staring at the ceiling tiles, lights are on, but nobody's home, kind of thing. That's a form of delirium. And then there's mixed subtype, which is about probably the most common, about 2/3. And they're the patients who have fluctuations. They can be agitated, trying to jump out of bed 1 hour, and a couple hours later they're completely unresponsive and you can't arouse them to sternal rub. That's called the mixed subtype, and that's the most common. And the hyperactive type we all think about is actually very rare, 1% or so. Again, age, older the patient, higher the predictor of having delirium, especially hypoactive delirium. Onset's typically by day 2 in ICU, And in general, like I said before, it typically lasts 3 to 4 days in ventilated patients if we're minimizing our risk factors. Because certainly there are things we're doing in ICU that can prolong the duration. Okay, so this is just a graph showing the different subtypes again. Hypoactive is the black bar here, and you can see that that's the least common type here. You know, less than 20%. The mixed, the darker gray, which you may be able to see, is the most common type. And then pure hyperactive is very small. So why do patients get delirious? Well, there's a lot of reasons. Obviously they're sick, so you got to think of the brain as an organ just like your kidneys and your liver and your lungs and the heart. We often don't think of how shock and hypoxemia and all these things affect your brain function. So really delirium is just like acute kidney injury. It's acute brain injury. It's disordered thinking caused by a whole host of problems, and it can be anything from severe hypoxemia, it can be from cytokine storm from sepsis, it can be from increased dopamine activation from medications we're using, anticholinergics like Benadryl or glycopyrrolate that you might see used in the SICU. All these things can lead to delirium. But the most common is just being critically ill. The other things that can do it are infections. So if you see someone who's been doing great, but then they get delirious, sometimes that can be an early warning sign that the patient's getting septic and something horrible is going on. So it should raise our warning bells that something's changing with the patient, especially if they've been doing really great and then all of a sudden have a change. Alright, so this is really interesting stuff here with delirium and clinical outcomes. So very well documented, the longer patients are delirious, the longer they're stuck on the vent, the longer their time in ICU. Typically delirium patients versus non-delirium patients is about 3 days longer ICU stay, a longer hospital stay, increased time in the vent, almost more than double, much higher costs associated with delirious patients. It's estimated up to $16 billion are costing in healthcare spending for treating this. Also, really important, there's actually increased risk of death in patients who are delirious, 3 times increased risk of mortality, and these are other really bad things. We are very aware now that patients who have bad delirium have really significant cognitive impairment later on. Once they survive their critical illness, they go home, especially if it's one of you who are young and want to go back to work at some point. A lot of these people, up to half of them, can't perform their normal functions. They have memory problems, they can't get back to their normal job, so it has a significant impact on their quality of life afterwards. There's association with dementia later on in life. Also, this group just published a study a couple months ago that actually looked at MRIs of patients who had delirium and compared to patients who never had delirium, and what it's showing is that basically patients who get delirium have atrophy of their frontal lobes and their hippocampus. So there's definitely some structural changes going on with these people, and it's not something that's going to go away. If your frontal lobe gets atrophied, it's not coming back. So there's definitely bad things going on. So we want to try and minimize it as much as possible. And this is just data from a little pilot study they did looking at delirium and hospital length of stay, and they clearly showed that in 80% of their patients who had delirium, they had a higher length of ICU and hospital stay. It was the strongest predictor of length of hospital stay even after adjusting for severity of illness. So, well known. This is the study from JAMA back in 2004 that linked ICU delirium with increased mortality. These are some of the data here looking at the age. They're pretty even. Their Apache scores, the higher the Apache score, the sicker they are. Usually over 25 is considered fairly ill. They were both very sick. There was very little dementia in these patients at baseline. And they had a lot of patients with sepsis. As you can see here, like I mentioned before, patients who have sepsis are at higher risk from all the cytokine activation. So there's more association with delirium in septic patients. And here's really the bottom line, is that patients who ever had delirium in this paper had 2 times greater chance of increased length of stay in ICU, in the hospital, and 6-month mortality was worse. So definitely bad. This kind of makes it a little more obvious. So here you can see the big change in mortality out of 6 months. And this is breaking down by severe, moderate, and mild delirium. This is looking at healthcare costs. 3-fold higher rate of death, 1.6-fold increased ICU costs, and 10-fold higher rate of cognitive impairment and hospital discharge. So huge. And like I said, a lot of this is redundant. There's papers here looking at delirium with pneumonia, increased mortality, and increased chance to go to nursing home if you're delirious. Taiwan. Surgical ICU patients get it too. You're not safe. Sorry, girls and guys. Prevalence in surgical ICU in this paper, 70%. Longer ICU stays. This paper here from critical care looked at use of restraints as a risk factor, not just sedation as a risk factor for getting patients delirious. So how are we going to monitor it? Right, that's what we really want to talk about, right? So it's a serious problem. It's probably way underdiagnosed. So here's our goals. We want to assess pain, sedation, and delirium. We already do that, but we're going to do better at delirium now. So we do our pain scale 0 to 10. We do the RASS for sedation. For delirium, this is our new tool, the CAM ICU. Okay? So it's really pretty straightforward and easy. It shouldn't take more than a minute to do. And we're doing it because it's quick, and if we don't look for it, we're going to miss it quite a bit of time. So how do we figure it out? Well, the key feature of delirium is inattention. So that patient whose eyes are open but nobody's home, that's inattention. To someone who is attentive and has normal brain function, normal thinking patterns, should be able to follow your command. They should squeeze your hand. They should stick out their tongue. Those are signs of at least something's working. I mean, we can still delve a little deeper and still find some subclinical delirium, which is part of the CAM ICU, but for the most part, intubated patients aren't going to be able to tell you if a rock floats on water. So we're going to skip those questions. But the key is inattention. So to look at the CAM ICU, the first thing is going to be to look if there's acute onset of mental status changes or fluctuations one way or the other. And then are they inattentive? Are they able to follow commands? So you need to have 1 and 2 and either disorganized thinking or altered level of consciousness. So if you have any of your patients who have fluctuating mental status in ICU, that's a check. If they're not following commands, that's number 2. You need one or more of these. Most of our patients can't show us they have disorganized thinking, but there are going to be occasional, like maybe if it's a cabbage patient who's extubated but they're acting a little confused, if you do the step 3 questions, you might actually find that they test positive. So if they have 3 out of the 4, they are positive for delirium. That's simple as that. Okay? And pretty much any patient who's in the ICU is going to have altered level of consciousness, so they're going to get credit for that even if they're on sedation. Okay? Alright, so step 1, you're going to do your RASS. If the patient opens eyes to voice, then you're going to go to step 2, and that's when we're going to go over the content and the delirium assessment. And here it is. I think you guys have a copy of this, right? Okay. So the first question is the patient different than their baseline mental status, yes or no? Or has the patient had any fluctuation in their mental status in the past 24 hours? So yes or no. If yes, you're going to go to step 2 for inattention. So I think probably easiest to do is open your eyes, squeeze my hand, wiggle your toes, those kinds of things. We do it every day, hundreds of times a day. They suggest doing serial A's, and they have a little phrase they use. I think it's like HART or something, H-A-A-R-T. You're supposed to have the patient squeeze your hand every time they hear the letter A. What is it? Save a heart? Thank you. Thank you. So that's one way to do it. But if they can't do that, then they have inattention. So that's another positive. Oh, here it is, save a heart. Alright, so if you get those two steps, you can probably skip these if they're intubated, because these are questions. Will a stone float on water? Yes or no? Will a leaf float on water? Are there fish in the sea? Does 1 pound weigh more than 2 pounds? Can a hammer pound a nail? So if you ask those questions, they're not making any sense. They might get scored for that. But if they have altered level of consciousness, if any of the RAS is other than 0, they get credit for that. So if you have 1, 2, and 4 positive, they're going to have test positive for delirium. Does that make sense? Okay. And this is the website. Here it is, ICUdelirium.org. Through the video. Alright. This paper just shows that it is easy to do. It's been done a lot of places, and I think we'll be able to do a good job bringing it here and making sure that we get it done. And it is easy to get good compliance. This paper, just some data from Vanderbilt showing that it was very easy to get almost 100% compliance with the CAM ICU testing. And actually some of the nurses are doing it more than once a shift, because I think once you get used to what we're doing, it's fairly simple. Not meant to overburden anybody. Can it be done correctly? Well, yes, this was just looking at agreement between the nurse at the bedside performing the test and another standardized rater, and they had almost 100% agreement when they used the scale together. So if I do it and then you go in and do it later, we should get probably the same thing if we do them pretty closely together in time. Alright, so how do we manage these patients? Well, I'll tell you, the answer is not more benzos. Okay. I think the thing to remember is that the main risk factors are age, severity of illness, hypoxemia, any kind of metabolic disturbance or electrolyte abnormality, hypoglycemia. We need to correct all those things. If there's an infection, we need to treat it, obviously. But the things that you at the bedside can have the most impact on is trying to use the right medications, not overly sedating people, and really trying to stay away from hammering with the benzos. And this is stuff I already talked about. These are risk factors. We have no control over this, so patient's age. Again, you can look to see the age goes with probability of delirium and severity of illness. This is the big one. So this is a take-home for you guys. This looks at total cumulative dose of Ativan or Lorazepam and risk of delirium. By the time you get over, I think it's 20 milligrams of cumulative Lorazepam, there's a 100% risk your patients are going to be delirious. And it adds up pretty quick. If you're pushing 2 to 4 milligrams every couple hours, by morning shift or evening shift, your patient's going to be delirious. So we really have to try and minimize that. So prevention is better than treatment. So that's why we're trying to get a protocolized approach with good monitoring. We're going to treat underlying causes best we can, correcting metabolic disturbances, frequent reorientation. Your family may be helpful if they're in the room to help reorient your patient. Very focused goal-directed sedation and analgesia with daily wake-up assessments. Daily breathing trials to try and get them off the ventilator as fast as possible. Early mobilization and physical therapy can be helpful. The other things we can do are trying to get patients normal sleep patterns, quiet time at night, keeping the lights out, trying not to interrupt them as much as we can so they don't have horribly disorganized sleep. And then we get to the cool stuff, the drugs. The most common thing we're going to use, well, first we're going to stop any drugs that are causative, such as benzos. We're going to try and stay away from anticholinergic agents. The most common ones we're going to already see now is Haldol. And typically, if the intern's ordering a 0.5 milligram, that's not going to do it. You need to start with probably at least 5 to 10 milligrams and give escalating doses. Also, drugs like Seroquel and Risperdal are very good at treating this. There's good data to support their use in these patients. And I would suggest if patients are testing positive for delirium, you get them on some scheduled Seroquel or Risperdal and use Haldol for breakthrough agitation. And then obviously these drugs can all prolong the QT interval, so we're going to have to watch EKGs so we don't have any bad side effects. Alright, so basically we're not doing anything different, we're just trying to do it more thoughtfully and in a more safe manner, okay? And I think over time we'll be able to do this. I think when we're rounding every day, we should really be talking about our goal sedation levels for the day. We should also be talking about how our patient tested on their CAM ICU and making sure that we're achieving our goal sedation and pain control, and then really addressing what we're going to do for delirium. The answer should not be, well, we'll schedule more Ativan. Okay, I think I've said that about 100 times so far. That's really important. Okay. Any questions? Yes, ma'am.
How does the CAM ICU work with a head injured patient?
Good question. So, as far as I'm aware, it's validated in all sorts of critical illness. As far as how useful the data is.
Well, I'm just thinking, you know, they have a lot of fluctuating mental status anyway.
Yep. So I think we should still use it and use that information. There are some times when you're not going to be able to treat as aggressively because things like Haldol can lower the seizure threshold, and if they have a traumatic brain injury, they might be more at risk for seizures, or if they may already be having seizures, so that's going to limit some of our therapies. But I think it's better to have the information and have the team that's rounding the patient decide what to do with it. But as far as I'm aware, it's been validated in brain injured patients as well. And if I'm wrong, someone can correct me. Anything else? Wow, that was easy.
So I have
Yes, yes.
in the video that we watched, the nurse or whoever was doing the CAM ICU had pictures and was like going through a lot of pictures. Is that something that like we would keep that card in the rooms to like use like for assessing this CAM ICU?
I think we certainly should keep them around. I think most of our patients that are intubated you're gonna get the information without going into this organized step 3 portion.
Yeah, but
Although some cards might, if you had to, yeah, we're gonna need them somewhere. You can either get them off this website, or we should probably have them somewhere in the ICU for the nurses to use, because it's going to be the patient who's not intubated that's talking but acting kind of goofy, and the family says, he's not right, I don't know what's going on. Those are the ones you're going to want to test a little more thoroughly, because you might find they have subclinical delirium. Okay. Yes?
So has Haldol changed? I mean, it's never really been great at ordering, because it used to be that it should have been like an escalating dose till you got to goal.
Yep.
And I never see it like that. I don't know if it's just changed or what the best practice is.
No, I don't think it's changed. I think that just the younger house staff have never used it in that manner, so it's kind of fallen out of the culture here. But we're bringing it back. Okay. Anything else?
Quick question.
Oh,
You
yeah.
say they can prolong the QT interval. Is
Yeah.
just our regular ECG monitoring okay, or do we want a 12-lead?
We need an EKG, and you know, Haldol in these doses for this kind of stuff is not FDA approved, so we really need to be doing EKGs probably every 24 to 48 hours if we're really being aggressive. I think you can use the telestrip as a rough estimate, but we really should have a documented 12-lead in the chart.
So if people are on, if that's just Haldol, or is that Seroquel?
It could be all those drugs can do it. So specifically Haldol IV, you need to be watching with EKGs, but Seroquel and all, you have someone on Seroquel, Haldol, and they add Levaquin or some other fluoroquinolone, they could go into Torsades. So we need to get 12 leads.
And would you recommend getting a baseline EKG prior to administering the Haldol?
I would. I think most of our patients in MICU probably have one, but if they don't, they should.
Who's going to document that QTC? Because you actually have to figure it out. It's not like just doing QT.
Yeah.
The monitors do that.
Yeah.
You can hit it on the monitors.
But I'm saying so I guess we would be.
Well, we're going to have in the chart, the resident or the team should be looking at it if we're doing a 12 lead. Okay. Yes.
Is there a max dose per said that would cause that delirium? Like, you know the chart you show with the
Yeah, Ativan. I don't know off the top of my head, but I'm pretty sure that all the data for any benzo is very similar to the lorazepam. Lorazepam has just been most studied because for a long time that was the most common continuous sedating agent. But we do know that if you compare midazolam to lorazepam, midazolam has a shorter half-life, so that's probably superior and has probably the least overly sedating effects comparing the two. But I think pretty much now it's known that all benzos are pretty much evil. And 1980s ICU, and we're 2012. Okay. All right. Thank you.
Thank you.